Welcome to Let's Talk, a place for straight talk on hard topics with smart people. And I'm pleased to be here today live from the SNMMI meeting in Toronto with Dr. Rich Wall. So thanks for joining us, Rich.
My pleasure.
So Rich, there's about 100 topics I could talk with you about that would all be interesting and insightful, but I want to focus on one today because it's something I hear lots of people talking about, and there doesn't seem to be one clear landing point, which is post-administration imaging of radiotherapeutics. And what should we be doing? Why is this so controversial?
I would say it's a topic in evolution, but I have strong feelings. We've made it routine in our clinic that we will do post-treatment imaging, typically 24 hours or so after therapy with PSMA targeting agents and also with somatostatin targeting agents. So it really does verify a couple of things. One, it tells us it's sort of a new baseline for where our disease is. The radioactivity is already in the patient, so you don't have to give an additional dose to tell where you are. And the other thing is, not uncommonly when patients are referred from a distance, there can be a delay between the baseline PET study that shows they have the right target and the administration of the therapy. So sometimes their disease might have progressed between when they had their PET scan on the outside, let's say it was 45 days before, and by the time you get insurance clearance and everything, 60 days to do the therapy. So if you do a PET scan after this, you might say, oh, the patient has progressed, the therapy hadn't worked. But if you do we found this not infrequently, that the new SPEC study after the therapy provides a new baseline for us to start from to tell us really the state of the disease when we started. Because some of this disease progresses rapidly, and you need to know. And you don't want to make a false conclusion. The other thing, of course, just from a practical standpoint, Medicare pays for post-therapy SPEC, so patients can have that. Some places have done it on the same day as therapy. Our preference is the targeted background ratios are higher later. We prefer the day later. The other thing is there's data recently published that show that changes in this post-therapy SPEC appearance after a couple of cycles are predictive of outcomes. So they can really tell you if the treatment is working, if the treatment needs to be changed. And I think that information will be critically important, as we move forward.
So what's different though, so most of the nuclear medicine field has spent a lot of time on diagnostics, right? Decades. And as we move into this therapeutic space, one of the things that's different is some of this radioactivity, it goes somewhere and it hangs around a while. And obviously that varies by drug and by patient. Does that change our thinking? How do we know when to image after an injection?
Well, I think that this is still being looked at, and I think it depends on what kind of scanner you have. The higher target to background ratios allow one to image sooner after injection, and higher sensitivities of cameras can allow one to image sooner after injection. So I'd say it's still of an open issue. In our hands with the therapy doses that we've been using, we feel that we're doing quite well with waiting a day after the therapeutic dose is given to get our baseline. But sometimes we'll get it on the day of therapy for patient convenience. Lutetium, as an example, has a relatively low abundance of photons. So waiting a longer time, you'll have fewer counts. But the other thing we didn't talk about, in addition to just a qualitative assessment of where the disease is on SPEC, and you can do planar, but the SPEC, we really prefer whole body SPEC. You see more, you can tell where the lesions are located. In addition to knowing the new baseline of where the disease is for subsequent comparison, you can quantify the uptake. And the quantification of uptake, especially over time, is how you get radiation absorbed dose to tumors. And that those sequential images can be very helpful to try to identify what the tumor dose is, but perhaps more importantly, what the normal organ doses are, such as kidney dose. So those, I think, data will be increasingly important as we move our therapeutic paradigms forward.
I'm quite sure you've heard some of the more animated discussions at some of the meetings is that while it sounds nice to be able to monitor these patients maybe over a longer period of time, 4, 5, 6, 7 days post-injection, that's just not feasible for so many of these patients, that it's not well tolerated by patients. It's just not something some people feel comfortable doing. What does that mean for the field? Is it okay if we're just taking that? Because I worry that a single time point is a snapshot, and I know what's happening right then, but it doesn't necessarily give us the whole view of what's happening overall post-administration.
Well, I think you're right. I think that's why iPhone has a choice of video or snapshot, and video is important. You can capture much different by knowing the temporal sequence. I mean, some patients, in some situations, you can get reasonable estimates of radiation absorbed dose from a single time point. So the single time point at a day after injection, I think, is important to tell tumor burden. You can actually measure the tumor burden. You can get the metabolic tumor burden, and that has prognostic significance on its own. And that change in metabolic tumor burden over in a couple of months will be predictive of outcomes, significantly predictive of outcomes. So that is different than the dosimetry. But to get the dosimetry, especially if patients have physiology that's not the same, and patients are individuals, you can get the individual estimates of radiation absorbed dose by having these multiple time points. This is probably of greatest relevance, in patients who have maybe altered function, like impaired renal function, one kidney. We do patients on dialysis. There's a lot of situations where you might want to know the individual patient dosimetry. The other emerging opportunity is retreatment of patients. We have patients who do well with therapy. I think in general patients are being probably underdosed with current regimens, the FDA approved regimens, if they tolerate them well. So knowing this dosimetry can also give confidence that additional treatments, which would be off-label or with a different agent, could be helpful. But back to your original point, we just haven't been doing imaging after therapy, and we're not going to change. I mean, I think that would be. I don't know if I would say it's a Luddite view, but I'd say it's a view that isn't forward-looking. I mean, I've lived through a lot of changes in nuclear medicine over the past 4 decades, and a lot of things we're doing now were thought to be impossible when they were first introduced, or certainly improbable. And I think, having a lot of experience, and got a son who's a radiation oncologist, where the patients are happy to come back every weekday for a 6-week period, 30 therapies, 35 sometimes, to get their therapy. Patients with cancer want to have their cancer treated the best way possible. And I don't think it's an unreasonable burden at all to ask patients to have imaging after therapy. And we've had excellent success getting our patients to come back and have these images.
So why do you think, I mean, I don't think you know, but just to hear your theory, why do some people not have success? They claim their patients don't want to come back.
Well, I mean, I think from a patient standpoint, spending as little time at the hospital and as little time in the therapy chair is important. And I mean, you have to be very respectful of patients' time and what benefit they get. But I think if it's an important measurement and an important determination, patients are very willing to come back if it'll make their treatment better. And I think we're still evolving how much it will make our treatment better. But I think we can say right now that knowing where you start with your disease is incredibly important. That is found on post-treatment imaging. Knowing how much that disease changes with the therapy is incredibly important. And that can be found on post-treatment imaging, and you don't necessarily have to get another PET scan. So you can get this, you've given the radiopharmaceutical, you've got this photon flux, to have to get another PET scan might not be the most cost-effective approach. Getting these scans afterward, I think, are also important. And then they're quantitative, which can lead to the ability to estimate radiation absorbed dose.
Do you think there's a factor? Because I've personally been one who felt like, yes, I think it's valuable to bring these patients back. It might be a bit of a burden, but worth it. We're saving their lives. But the difference between a lot of these patients and traditional external beam radiation therapy patients is they're sicker. We're now dealing with post-chemo patients mostly at this point in radiotherapeutics. And these are, you've got a lot of stage 2 type patients going through radiation therapy often, even maybe a stage 1. And so do you think there's a real difference in the patient populations we're serving right now, and that maybe this imaging burden is higher than we think, which doesn't mean we shouldn't do it, right? But, does that make a difference here?
Yeah, I think that's a fair comment. I mean, I had a patient just last week who was very uncomfortable lying down. It was quite difficult for them to tolerate their imaging. And I mean, I think you have to be mindful of the individual patient and what they can tolerate. I mean, if a patient's in severe discomfort, and can't lie down for a scan, they may not be as good a candidate for repeated imaging. But on the other hand, sometimes those patients are the ones who may get the greatest pain relief from some of our therapies, and getting it right and making sure that that therapy is available may be best for them.
Yeah.
So it wouldn't be fair to say no pain, no gain.
Yeah.
But some pain, if there is a gain,
Yeah.
may result in less pain. So but I do think it's an evolution.
Yeah, and I think you made me think, I know you collaborate well with your radiation oncology partners, at Washington University. And I think also you made me think that I'm seeing more discussion about just, a resurgence, maybe an external beam radiotherapy to consider palliative whole body treatments, just to kind of help these people feel better. In which case, that does it become important that they have some sense of the absorbed dose that had been delivered in the radiotherapeutic phase?
Oh, absolutely. How one combines external beam with dose from radiopharmaceutical therapy will be of relevance, is likely of relevance. The other thing I think is emerging is certainly the use of PET, and I think maybe even these post-therapy specs to guide external beam stereotactic radiation to what we call oligometastatic disease, that is limited foci of disease, maybe not controlled well with the radiopharmaceutical, but might be controlled with external beam. Let's say they're symptomatic. So being able to sum up the dose from the different sources, I think is going to be important.
Does the society have a position on things like dosimetry or number of imaging time points yet? Are there task forces? Are there guidelines?
I know there's a task force working on recommendations on the post-treatment spec.
Yeah.
I personally have advocated for it becoming more routine.
Yeah.
But I think, the reality is we need to accumulate more data. There are some patient access issues in rural areas where they may simply not have access to SPECT CT. So there may be some situations where you won't be able to do that. But I suspect will more strongly be recommending SPECT in the future in these patients after treatment.
Well, great having you here.
Really a pleasure to meet you.
Yeah.
I've heard a lot about you.
Oh, yeah. Thanks for joining me and Dr. Wall today. Let's talk again soon, Rich.
Yeah, maybe in a couple of years.